up next, we have what more you can do with data and regarding clinical guidelines. This is a three-person panel. As you see, a new chair got brought up. Thank you. And we're going to welcome up now Paige Newis, Director of Family Empowerment from Rett Syndrome. Paige leads initiatives building bridges between Rett Syndrome patients, families, clinicians, scientists, and industry members. She seeks to stimulate participation and engagement in research activities and build centers of excellence, fostering patient-centered research development and design. Bernhard Suter, PhD, Assistant Professor of Pediatrics from Baylor College of Medicine, joins us as well. Bernhard focuses on the care of children with neurodevelopmental disorders and autism and strives to unravel the underlying cortical network dysfunction leading to motor deficits in a mouse model of autism. And finally, Dr. Daniel Glaze, PhD, Professor, Department of Pediatrics and Neurology, also of Baylor College of Medicine. He's focused on Rett syndrome and natural history studies, including genotype and phenotype correlations, quality of life, and survival. He's interested in the correlation and characterization of sleep behavior in children with rare neurological disorders, as well as a study of sleep, cytokines, and impact on daytime functioning in children infected with HIV. We always love to feature our kind of home turf folks, so really, really proud to be able to bring some great stars from Baylor out. So please welcome to the stage Paige, Bernhard, and Dr. Glaze.
Paige.
Thank you. Thank you, and hello, everyone. It's not only hard to go after Eddie Vedder, it's hard to go after lunch in the late afternoon. So I hope we all are doing well. I'm going to stand at the microphone. Dr. Glaze and Dr. Suter are going to have a seat.
Okay.
Okay.
I think I'll come up to the microphone if that's okay with
Okay,
you.
sure.
Great.
Yeah, we'll come and go, come and go.
Okay.
This is going to be interactive. We're very excited to be here today. Thank you, Global Genes. Thank you, CZI. This is an incredible opportunity to have all of our rare diseases come together and talk about our collaborations. I'm the Director of Family Empowerment with RettSyndrome.org. I have a daughter with Rett syndrome who's 17 years old. I got involved with the foundation about 5 seconds after her diagnosis when she was 17 months of age. I live in California. At the time, we enrolled in the natural history study for Rett syndrome. But I didn't know that that's what I had done. I just got on the plane and flew to the closest center of excellence for someone to see my child, and that was Dr. Glaze. And someone was talking about earlier, they don't really remember the moment of diagnosis and what were they handed. I didn't remember signing a consent form to participate in a natural history study. I just said, sign me up, take whatever you want. I'm just here to learn. And it's been a long journey, a 15-year journey of relationship building, convergence, divergence. I'm not here today to talk about our research strategy. We have a very strong research strategy at our foundation. We've been funding basic science, translational science. We have assays, we have cell lines, we have clinical trials. We're on the verge of a gene therapy trial. And those are all very wonderful, exciting moments in time. But through our conversations with Global Genes, they heard our story of the other things that came out of our data collection and came out of the process of organizing our data. And as the Director of Family Empowerment, I'm here to talk about that portion of the story of we as patients, patient families, talking to the investigators about what more can we do to take care of our children now while we are advancing research, because these things are arm-linked and they don't have to be distinct, separate efforts. They can be collaborative. So quickly, what is Rett syndrome? Rett syndrome is a rare non-inherited, primarily, genetic disorder that affects approximately 1 in 10,000 females. Pretty rare. We have between 5,000 and 8,000 diagnosed girls and women and some boys in the United States. It begins to display itself in missed milestones or regression at 6 to 18 months of age. It leads to severe impairments affecting nearly every aspect of our children's lives, their ability to walk, talk, breathe, digest, almost every symptom. So we as parents are the real advocates in this story. We are their arms, their legs, their voice. The hallmark of Rett syndrome is near constant competitive, repetitive hand movements while awake. Cognitive assessment is difficult in our children with Rett syndrome. In 1983, it became widely known as a distinct disorder in the US and worldwide. And at that time, it was a clinical diagnosis. And that continues to today, that Rett syndrome is fundamentally a clinical diagnosis. But in 1999, we discovered the causative gene, right here, Dr. Huda Zogby at Baylor College of Medicine. So it's really nice to be here at the origins. And these were all before my time. It's a single gene that results in Rett syndrome. And sitting here in 2020, we have approximately over 95% of the cases can be confirmed by that MECP2 mutation. So that's what we're dealing with. Now I'm going to advance my first slide. There we go. So our story of data really is a journey, a longitudinal journey, and we're going to highlight some of the points of convergence and divergence and collaborations that came out of that journey that hopefully you all can leapfrog us and apply in your disorders now. So in the 1980s, a lot of diverse data sets began. We began as a patient advocacy group in 1984. At that time, there were 5 clinics in the US, which meant there were 5 doctors. We call them clinics, but there were really 5 doctors in the US who knew about Rett syndrome, and there were 7 doctors in Europe who knew about Rett syndrome. And they had patient advocacy groups, parent associations that got established in those countries. And people started collecting data, but not in any kind of way that we talk about it today. Post gene discovery, there became a real energy in the field to move beyond taking care of patients, identifying patients. It energized the field to turn from what caused Rett syndrome to how to cure Rett syndrome. And it brought together an incredible energy amongst the advocacy groups and the parents. We thought, okay, now that we know the gene, we're going to have a cure for this thing. Well, it's 2020, and we're still not there yet, but we haven't lost our optimism or our hope or our enthusiasm or energy. But the efforts that happened then at the turn of the century, I can't believe I'm saying that, at the turn of the century, brought advocacy groups and researchers together to find we had the patients as advocacy groups, so we then needed to test them to confirm the genetic marker. And that created another layer of people in the field. That brought in geneticists, and that brought in other labs to work on discovering the mechanism of the disease and the pathways to treatments and clinical trials. And it also began a journey of assessing the disease state based on genotype and phenotype. Is it a spectrum disorder? What do children look like? What do adolescents look like? What do adults look like? What is the longevity? These are questions that needed to be answered. So let's say then around that time there were 5 clinics in the US, and they were really clinics that grew up around those neurologists and the ones who had made their mark for their careers in this disorder. Few short years later, fast forward to, we were talking earlier today, a few people have mentioned NCATs. In 2003, the NIH Office of Rare Disease Research and NCATs created the Rare Diseases Clinical Research Network. And the PIs in our field came together and applied for a grant in the natural history study. And Dr. Glaze is going to talk about this journey. But really, this initiative came out of the NIH because they identified that clinical research is as important to the value chain of identifying cures and treatments as basic and translational. And this was really at a point in time where clinicians began to do research with patients. And it was a really incredible decade, leading almost into 2 decades now, of data collection where PIs were required to work with advocacy groups in order to have this grant. And it was a pretty incredible story. So I would like to, a few other things, a few other reasons for rare diseases is the hurdles, few patients, widely dispersed, challenge for recruitment into studies, few expert centers for diagnosis, management, and research. And so their solution was to create clinical research consortia. And this is where Dr. Glaze can begin the story that began here in Houston, Texas, and expanded across the U.S.
I'll do it by
From here?
sitting, yeah. I'm going to take advantage of the sitting. I've never given a talk sitting. It's sort of like being with my grandchildren. We sit around and read the book to them. I understand that I actually was introduced by the previous speaker because of my interest in sleep and in Prader-Willi. And so you have some knowledge of me anyway. I have to correct one thing. I'm not a PhD. I'm a MD, physician, and all my experiences are from that perspective as a physician. I also wanted to give a sort of prequel. Before the gene was discovered, we were busy and we were excited about Rett syndrome. And between 1983 and 1999, there was still a lot going on at Baylor College of Medicine. And it was through the mechanism of a program project. And what happened was a number of clinical investigators, including myself, got together and said, we're interested in this. I was interested in epilepsy, in sleep. We had others interested in GI and so forth. And we came together and proposed a program project concerning Rett syndrome. The mechanism actually was a drug study, and based on a recent clinical finding of elevated levels of beta endorphins in the spinal fluid of individuals with Rett syndrome. But on that basis, it allowed us to do some other things, collect a lot of data and start learning about Rett syndrome. But we learned from this project, I think, at least three things. One, that we actually didn't have good assessment tools, outcome measures, that we needed to develop them to be specific for Rett syndrome. Number two, we need to identify more patients to enlarge our sample and to make something of the data of the studies that we were doing. At that time, there was no genetic marker, so the diagnosis was based on clinical criteria. And so we tried to use that as a standard in order to identify patients who met that standard. The third thing we learned was a positive thing. To care for individuals with Rett syndrome, children, their families, and as they became women, you needed a multidisciplinary team. A neurologist couldn't do it by themselves. A primary care physician couldn't do it by themselves. And so this led to the formation of a clinic, which was a multidisciplinary clinic. So we have all that going on, and it comes to be discovery of the gene, and then it becomes to be 2003. And as been outlined here, the hurdles were, we had identified a few patients. A large number of patients lived in Texas. Being Texas, we have large things here. But many patients lived at a distance, making it difficult for their families to come to our center to participate in this research. And as Paige has said, at that time, there were only a handful of physicians who knew anything about Rett syndrome. And so there are few experts, patients, by virtue of the fact that it's a rare disease, had been relatively few had been identified. So there was a need to increase that. And so the first solution that came up was the putting together of consortia of rare diseases, like a consortia of Rett syndrome, which would bring together numbers of clinicians who knew or had interest in Rett syndrome, and two, bring together a larger group of patients. Paige has kindly indicated here that the NIH has allotted some $31 million in developing these consortiums. Okay, now I'm going to learn how to handle this. Yep. One of the positive things about this rare disease clinical research network was it established a primary database, data management in South Florida. And that had several positive effects. One, as indicated here, all of the protocols associated with this network were listed on clinicaltrials.gov. The importance of that is twofold. Other researchers who might be interested in doing similar studies or investigating similar rare diseases could go there and find out who's involved in the research and therefore get in contact with them. Second, it allowed families to go to that site and identify researchers, clinical researchers, basic researchers who actually are involved in trying to understand the disorder that their children had. And the next thing was this management coordination center in South Florida provided technical support, tools available to us to design studies, protocols, and to manage them and manage the data and statistical analysis. So again, the positive benefit of this data management was that, again, it provided online protocols, how to manage them, how to design them, put them together, how to collect the data. It designed the questionnaires and helped with designing the questionnaires that would collect data for us, storing the data, and also data analysis. So this was a powerful tool that we had in hand in order to do the research, to address those hurdles that we've mentioned. And lastly, it would oversee the registry. And the registry is important because a list of all patients enrolled in rare disease, with rare diseases enrolled in these projects, is important. When you do come to clinical trials, you then have a group of patients you can identify, bring into the clinical trials. They could be identified by their characteristics, disease, and so forth. The initial natural history study we did was the basis or foundation would be the U54 grant. This is a way of establishing collaborative associations with other like-minded clinical researchers and basic science researchers. It allows a foundation of acquiring information, data, knowledge, storing that, analyzing that data, again, help establish uniform protocols that could evaluate groups of patients. The database, as we already had established in Florida, would serve the purposes of the U54 grant. And again, the cost-sharing research infrastructure was built, so we were ahead of the game in some ways for the U54 grant. And then the hope was it would help establish more centers, identify additional patients for an increased sample size, and help us understand these rare disorders. And again, these are things that I've already covered. I'm going to skip on. So a cooperative agreement was established among three different groups of rare diseases. This began at Baylor, was led by a geneticist, and then subsequently was led by Dr. Percy, a specialist in Rett syndrome. The three groups that were identified and brought together were Rett syndrome, Angelman syndrome, and Prader-Willi syndrome. And again, the focus of this initial study of bringing these three groups together was the same for all three groups. It was a longitudinal natural history study. However, data collection was by specific protocols unique for the disorders that took into consideration the unique phenotypes clinical characteristics of the disorders. For the Rett syndrome, which is one of three groups of being studied in the initial natural history study, there would be 3 sites. I think, as initially said, we started out with 5 sites across the United States in sort of that pre-natural history era. But 3 sites were identified as with investigators interested in performing and being part of this natural history study. These were the Baylor College of Medicine site here in Houston, the University of Alabama in Birmingham, and the Greenwood Genetics Center in South Carolina. And again, we had an ambitious goal. We were going to enroll 1,000 patients with confirmed Rett syndrome. By 2006, the study had finally got up and running as protocols had been developed. Things had been worked out with the Data Management Center and with the Rare Disease Research Network. And again, the purpose of this study was to expand the phenotype-genotype studies that we had initiated, as well as perform a natural history study. We soon discovered the same hurdles that we had mentioned previously existed for the specific natural history study of Rett syndrome. Namely, there were a few patients that and that they lived across the United States, and many families had great difficulty in getting to the 3 centers which were in sort of in the southwest, southeast. And so that had to be overcome. Second, again, there were few experts and centers that were looking after individuals with Rett syndrome who had the knowledge to actually participate in this natural history study. So we came up with this solution, and this solution was accomplished with the support of RettSyndrome.org organization, the advocacy group for Rett syndrome. And what we came up with was to have traveling clinics. The experts, the physicians, the clinicians involved in the 3 primary sites in Houston, in Birmingham, and at Greenwood would travel to 4 additional sites. And those additional sites included Oakland, Chicago, a site in New Jersey, Brunswick, New Jersey, as well as a site in Florida, giving us the power of having increased exposure, identification of patients. But we could do one other thing which became important for the future. We could identify clinicians at these traveling sites who had an interest and the ability to actually start up and become the owners of the Rett clinics in these locations. So we not only were increasing our sample size, enrolling more patients, more families into the study, we were identifying clinicians who could carry on the job in the future as the studies, as the activities expanded. In 2009, it came time to renew the natural history study. Again, the focus continued to be on the longitudinal natural history. The one change was we added an additional site in Boston, which would be a primary site in addition to the 4 traveling clinics. And again, we hoped by adding the additional site in Boston to increase enrollment, to increase our sample size, and thereby be able better to understand not only the natural history, but the day-to-day Rett syndrome problems. Again, RettSyndrome.org, the family advocacy group, continue to support us, to support the traveling clinics, and actually make it possible to accomplish these goals, certainly to enroll the 1,000 patients we had set out as our goals. At this time, it became apparent that certain patients identified as being Rett variants, not meeting the full clinical criteria or having a mutation, a typical mutation in MECP2 were identified. And these disorders included CTKL5 deficiency disorder and the FOXG1 syndrome, as well as the MECP2 duplication. It became increasingly apparent to us that we could no longer be a Rett-centered organization project, that we would probably have to consider these additional disorders as having a unique and identity of their own. In 2014, at the next renewal, the third renewal of the natural history study, because of the increasing experiences that we had, it became important to expand the study and to include not only Rett patients, but those other disorders. And the natural history study would include and direct it towards the full range of these disorders. And so it became a Rett syndrome and related disorders, rare disorders that were being studied. Additionally, the traveling clinics were essentially stopped for a number of reasons. Many of us had wives who said, this traveling is getting out. You're doing this 4 times a year and for every clinic. And so, but more importantly, it was time for those traveling clinics really to have an identity of their own, to have their clinicians identified as being Rett experts along with the principal sites. So those are the changes in the third edition of the natural history study. It continued to be a study of the natural history, the longitudinal natural history of Rett syndrome and these related disorders. There continued to be a single protocol that data was collected and entered into the database in South Florida. Again, principal sites were expanded to 11. RettSyndrome.org, the advocacy group, supported 3 additional, so we had 14 sites. So I hope you can all see the importance of that. One, from the standpoint of doing clinical research, if we were doing a drug trial, which it's typically done as a multi-center drug trial, we now had the ability to have 14 sites carrying on that trial, 14 sites identifying patients with the expertise to carry out that. Second, if you wanted to improve the care, you now have 14 sites with their own clinicians, experts, to also provide improved care, to join in as we planned and developed clinical programs for the care of these individuals. Again, the mechanism for this remained rare disease clinical research network, as well as the National Center for Advances in Transitional Sciences, or what is called NCATS. The current research goals of the current natural history study, again, is the longitudinal natural history, data collection on the Rett syndrome and the 3 other disorders, continue to do genotype-phenotype analysis. But again, it becomes twofold. One, for each individual disorder, doing a genotype-phenotype. So you could understand the relationship of severity to the underlying mutation, but also you could compare the individual disorders. You could compare Rett syndrome to the duplication disorder, to the FOXG1, to the CTKL5, and see how they're different, especially if you're going to develop biomarkers or outcome measures? Are they specific? Do they identify Rett syndrome versus the others, or are they more general and don't identify the specific disorders? We also have the ability to initiate sub-projects. And those sub-projects really are directed towards clinical trials. One is an event-related potential study using visual evoked potentials and auditory evoked potentials to see to get a baseline, what are they like in each of these disorders? Are there abnormalities? Could they give a physiological biomarker that could be used in clinical trials? And second, we wanted to collect samples for DNA, RNA, metabolome studies. And these samples would be stored and available to scientists around the country, where if they had an interesting project, which they could go to this repository and actually request and samples that would help them carry out their studies. So these things were established, and so now I'd like to sort of give an indication, what has been the outcome? As you remember, we said the first goal was to identify and enroll 1,000 patients. In the natural history study parts 1 and 2, we indeed exceeded that goal. And we, again, it was a Rett-centered protocols, and we identified over 1,000 patients either with classic or atypical Rett syndrome, as well as some patients who had mutations but did not meet the criteria, clinical criteria for Rett syndrome. The differences in natural history study version 3, starting in 2014, we've now been able to also identify a significant number of patients, individuals with the other disorders. And so you can see for classic Rett syndrome, we have a little over 600 patients, an additional 81 with atypical. But we've also enrolled patients with the duplication syndrome, patients with CTKL5 deficiency disorder, as well as FOXG1 disorder. And we're approaching, and again, our goals of 1,000 individuals or more enrolled in the study to give us good power to actually go back and analyze the data as to what are the characteristics, what is the longitudinal outcome. One reason for doing this study was to have this basic information. If you wanted to do a treatment trial, you would have to know, does it actually change the natural history, or are you just seeing what would be the natural history of the disorder? It would be the outcome with or without the drug. And so with the 1,000 or more patients, we have the power to determine that. We've enrolled and collected samples in 638 individual patients, individuals with one of these disorders, and the event-related potential study has been completed in 152. So substantial sample size. So what have we accomplished, and what has the data done? And one thing the data has done is allowed us to publish and provide information to the community of clinical and basic science researchers that will help them understand, design studies. And so this is also important, even if you're just working with a mouse, you have to know what the human looks like. Do you reproduce it in the mouse that you've created by with certain manipulations of their genetic makeup? Some of the important publications include revised and diagnostic criteria. This is important to establish consistency, a standard of making that diagnosis. Second, the phenotype-genotype analyses have been important in understanding the disease of Rett syndrome. Again, in Rett syndrome, there are over 200 different mutations in the MECP2 gene. And so you have to understand which ones are severe, which ones are less severe, what's the relationship to the clinical presentation, and the specific mutation. This becomes important when you're designing clinical trials, or if you're just taking care of the patient. What do you need to do differently for a patient with this mutation? What do you need to be telling parents what to expect because your child has this MECP2 mutation? And so it's important from the standpoint of doing clinical trials as well as the day-to-day care of the patients. The studies have included quality of life assessments. This becomes important because currently the FDA and the NIH, if you're planning clinical trials, wants to know how's the impact on quality of life. It becomes an important aspect of outcome measures for those types of studies. In addition, we've published on development of measures, of questionnaires and things that could be used in clinical trials. Additionally, we've had a few publications. The vast majority of publications have been concerning Rett syndrome, but we have had a few publications concerning the duplication disorder as well as CDKL5 deficiency. That amounts to about 28 different publications. In case you didn't get a chance to count, they were that. Currently, we have a couple under review and hopefully will soon be published, and we have about 10 in preparation being worked on at this time. So we have a significant body of literature, publications, of information, of data that we have gathered from the natural history study that covers the broad aspects of the clinical aspects of Rett syndrome. We're beginning to understand these other disorders and publishing on them. So what's the result of having collected all that data, of putting out that data? Well, one of our primary interests is, can we find a cure? Can we find a drug, a treatment that makes things better for individuals with one of these disorders? And in putting out this data and showing that we have learned about these disorders, especially about Rett syndrome, we've piqued the interest of industry, especially people who are designing medications that will design drug therapies or genetic treatments that might be useful in treatment of these genetic disorders. And this has actually come to some fruition in that recently we've completed successfully first studies of drug trials in Rett syndrome, and now we'll initiate a phase 3 trial of a drug called trofinetide in Rett syndrome. But again, the stage is set for these clinical trials by having this knowledge base collected by uniform protocols, having them in a data bank that can be managed, and the data can be analyzed, and we have the infrastructure in place for that data analysis, for management of data that will be useful in treatment trials. However, another important aspect, one that I've talked about, is the clinical care of individuals with these disorders. And supported by RettSyndrome.org, the advocacy group, they've initiated what is being called a P3. P3, the three things are projects, process, and publish after successful accomplishment of the project and process. The goal is to develop evidence-based guidelines and to establish those in the 14 clinics and care of patients with Rett syndrome. The current focus is on 4 important problems in Rett syndrome. That's communication. Remember, as Paige presented, these are individuals who lose the ability to use spoken language and depend on alternative ways of communication. And so we want to give recommendations for ensuring that the individuals have the chance and ability to develop alternative ways of communication. Epilepsy occurs in about 80% of the patients. However, there are non-epileptic spells, behaviors that many of the individuals with Rett syndrome exhibit, and so it becomes important differentiating the two and what's the best way of treating epilepsy. GI problems are almost 100% of these patients, and we're developing guidelines for management of GI problems and nutrition problems in individuals with Rett syndrome. And finally, a significant number of individuals with Rett syndrome will have what is called prolonged QT interval, which is an abnormal distance in involving the electrocardiogram, the signal of your heartbeat. And this is important because individuals with that are at risk for a fatal arrhythmia and early unexpected death. And so we think it's important to address that, provide clinical guidelines to make sure that that is evaluated and managed in to try to prevent sudden unexpected death and lessen the risk of this problem. Again, here we've used the word key thought leaders. Essentially, as we developed these 14 Rett centers with large experience with Rett syndrome, we've identified the key people at these centers, and they are the people who are developing the clinical guidelines. And so that has been a benefit of the natural history study. As you remember, 3 sites, now 14 sites. 3 people who knew about Rett syndrome, now dozens and dozens of clinicians who are very aware of Rett syndrome, who can address these clinical problems. And again, the RettSyndrome.org organization has established what is called North American Clinical Discussion Group, a group that meets quarterly to put together these clinical guidelines. So the bottom line is, what can you do with the data? It certainly can help you with clinical trials, which certainly for Rett syndrome have become a big, a great possibility. 2, it can help you establish clinical guidelines that will make the day-to-day lives of individuals with Rett syndrome better, improve them. Certainly the data can help you answer, can help me as a clinician address and answer questions that parents have. What's going to happen to my daughter? What problems is she going to have? How long is she going to live? What can she do? Can she communicate? Can she walk? And things like that. And finally, and this brings me to Dr. Suter's presentation, it allowed us to identify things that looked like Rett but weren't Rett, that had a unique phenotype identity of their own, and now how we're going to progress and help those individuals.
All right.
So great. Oh, in your
Fantastic.
hands.
All right. How do I advance? Next, I guess.
Is that okay? Oh, great.
Okay, Paige?
Yeah,
Yeah?
thank you.
Okay. Hello, everyone. I'm Dr. Bernard Suter, and I am a pediatric neurologist by training. I work in the Rett Center alongside Dr. Glaze have been working for a number of years now, and as of recent have become the director of the CDKL5 Deficiency Disorder Center of Excellence. And with that background, I just wanted to add 2 more sort of points of outcome or impact that natural history type data collection can have on the rare disorder communities. So as you all had heard, that initially the NIH Natural History Story had been collecting longitudinal natural history data on Rett syndrome, and then later also on Rett-related disorders, CDKL5 disorder, FOXG1 disorder. And in part, that is because of the following history. So in the late 80s and 90s, really the only entity that was somewhat well known, albeit was known with a very broad spectrum of phenotypes, was Rett syndrome. And in one of the early papers from that field by Hanefeld, in the mid-80s, he reported on a variety of patients in Germany with Rett syndrome, and one of them was an individual who had developed very early on infantile spasms, of type of seizures in the first months of life, who then later went on and developed many characteristics of Rett syndrome, including microcephaly, the midline hand-wringing, and other ataxia and other very sort of typical characteristics of Rett syndrome. And at that time, it was definitely classified as a variant of Rett syndrome. And then it took about 20 years to, I believe it was 2003 or 2005, that actually people went back with better genetic technology available then and rescreened for other mutations other than MECP2 underlying a Rett phenotype, and they found actually frameshift deletions in the CDKL5 gene, specifically in patients that developed seizures very early on. One patient that developed myoclonic seizures already at 1.5 months old, so very, very early on, and that previously were believed, or still were believed, to be variants of Rett syndrome, just sort of fitting in under the population that has Rett syndrome clinically, but does not have a MECP2 mutation, where I really apologize about that. I knew it would happen. And it's a spam call, I know. My apologies. And so obviously genetic screening was very, very important to chip away at these variant subtypes of Rett syndrome to see whether there are other entities within Rett syndrome that really stood out. But then it took almost another 10 years, and then based on natural history type data, until people recognized that really if you took people with CDKL5 mutations, they analyzed about 86 of them, and went through their clinical phenotype very diligently, that less than a quarter really fulfilled the clinical criteria of a variant Rett syndrome, which, importantly incorporates early normalcy, means normal birth and normal development in the very first couple of months of life. And they felt that, and they furthermore were able to chisel out that CDKL5 individuals had a greater preponderance of seizures and sleep disturbances, but much less of a real, true Rett-like regression and spinal curvature. And so based on this natural history type data that was the fundamental backbone for actually working out that CDKL5 is an independent entity, they were then able to develop separate clinical guidelines that are distinct for each disorder. Some of them are still in preparation, but you can imagine they need to be separate, as I just told you that in CDKL5 syndrome, for instance, scoliosis is not a very big issue, but in Rett syndrome it is a big issue and needs to be screened for much, probably earlier or with a greater emphasis at least. And then also, another outcome of it is that clinical severity scales could be devised that are really truly separate for two truly very closely aligned but truly separate disorders. And this could not have been achieved at all without very diligent natural history type data collection, database data collections about the phenotypes in other shapes and forms. In the second point that I just want to bring up, other than being successful and discovering separate gene disorders that are very closely related to Rett syndrome, these data collections can also aid in chiseling out whether other genes that now, with advancing technology, really cause an overlapping phenotype or not, or are for some reason or other a spurious case of a phenotype that looks like Rett syndrome. So there's a recent paper out there where with whole exome sequencing they revealed, believe it or not, 69 new genes that all could potentially cause Rett syndrome, because in one case they found a gene that, underlying these cases of Rett or Rett-like individuals. But again, natural history type data collection could be very, very helpful in chiseling out, is that just an N of 1, an example where that will eventually form an entity such as CDKL5 syndrome did, right? Or such, in this case, TBL1XR1, a paper that we had put together, where currently the data collection is very, very sparse, and they would benefit greatly from having a natural history type data collection, where case reports just do not really support on the clinical basis that TBL1XR1 causes a Rett-like phenotype. We stumbled upon one case where truly that individual had a Rett-like phenotype, or indeed fulfilled the revised clinical criteria for typical Rett syndrome, but no other case in the literature has had been described that really filled the picture, but the data in those clinical case descriptions is very, very sparse, so that the verdict in some sense is still out there. And that was basically my 2 cents page that I wanted to add with regards to natural history type data collection.
Thank you.
Mm-hmm.
So thank you. So as you can see, it's been a long, strange journey for us. And it's been a journey of convergence and divergence, and some really beautiful things that have evolved for these kids over time by having a collaboration between our patient advocacy groups and the investigators. I think our key takeaways are, we would recommend, is to commit to data harmonization. We don't know what tomorrow is going to bring. We don't know if the questions you're asking today are going to be relevant for what's needed to be known tomorrow, but data is rich, and you can learn many things from it. Funding needs change over time. We saw we have had to live within our means as a foundation. We have supplemented federal grants and other institutional funding sources along the way where we have felt we could add value. We felt that for our syndrome, adding value was expanding the bench of people who knew about Rett syndrome. As I mentioned, I am the Director of Family Empowerment. We have a Chief Science Officer who is marching forward our research strategy, but I'm the one who hears from parents every day who says, that's great, another paper was published on epilepsy and Rett spells, but I'm still, what do I do today for my child who is seizing? What do I do today for my child who's having a Rett spell, where epilepsy medications are not appropriate and aren't doing anything? And it's been this continuous dialogue with our investigators, which has led to the ability to publish care guidelines along the way. Because as you expand centers, not only are you collecting more data, you're collecting more people who are interested in the syndrome and can answer these questions. So we have more gastroenterologists, we have more neurologists, we have more endocrinologists, we have I think at one center we have 14 specialists who see our kids. And not all of them were particularly interested in Rett syndrome. Some of them came in because they were interested in CDKL5, or some of them were interested in MECP2 duplication. And what we did was we convened a meeting last year of all of these 14 centers and said, what could we do for you? What, as an advocacy group, as a patient advocacy group, what could we do for you? And they all resoundingly said, we need to know how to apply best practices of clinical care consistently across these disorders to all of the kids. And we also need to figure out how to transition kids to adulthood, because one of the, to me, one of the greatest outcomes from the natural history study has been improved care. So we now see our children living not into just young adulthood, but well to a near normal life expectancy. So that enters us into the next stage of care with Rett syndrome. And I would encourage all of you to continue this just a nice hum of effort in the background. It's not sexy, it's not fun, it's hard. We burnt out our PIs by funding them to travel to the patients, and then we fortunately didn't annoy them too much. We just burnt them out a little bit, let them rest and recover, and now they are mentoring other centers. So they share the work. They have incentive from us to publish guidelines and take better care of the kids. And as our clinical trials are successful and we have drugs come to market, is it going to be a cure? Is it an all or nothing game? I don't think it is going to be for any of us. Our children are going to continue to need care, but that quality of care is going to evolve. So to have people documenting fundamental knowledge, sharing best practices, and committing to publish guidelines that will not only help them go to their pediatrician or primary care doctor who's never heard of this rare disease, but also go to a center of excellence that may not be a major academic institution, but they're really good clinicians, and that they are going to get the same quality of care equalizes the field, so that families whose children are too sick to travel or they don't have the means to travel can have access to good quality care while we're on this fast pace towards a cure and transformative treatments. So I think we have made it within our time.
Do we have time for some questions?
To answer some questions.
If you could advance to the next slide, too. We have the polling question at datadiy4.cnf.io. It looks like some of you are already in there answering it, and a lot of people are working on it. Balancing out a little more. I think you made a wonderful pitch there, Paige, and thank you, Dr. Suter and Dr. Glaze, for your dedication over time and all the difference you're making in the lives of so many people. I think Paige originally talked about the fact that her story represents the real life of an advocacy group, and sometimes it takes many years, but all the accomplishments that you've made through your dedication are pretty amazing, all of you. We have some questions. Hira, maybe you'd like to start.
Yes, thank you, Dr. Suter, Dr. Glaze, and Paige. Thank you very much. So the most upvoted question right now, since we are in Texas, I want to ask the elephant in the room question. Are studies going on with THC for treatment? Asking for a friend.
Actually, this week.
THC.
Oh, no.
THC
Oh.
was the question, not CBD, right?
Not CBD.
THC specifically, but I'm sure people will be open to CBD as well.
Not THC.
THC specifically.
Paige, are you aware of any?
I am not. I'm aware of a lot of off-label use, but I am not aware of.
All right, thank you. The next question.
Could I just say
yes.
a word on that? More importantly, we are doing a study in CBD, and that is, it's approved by the FDA, and so you know exactly what the substance is, and if you do a study and you see the outcome, you know what you're dealing with. And so I would make that appointment. We are starting that study up this week.
And that study is not focused on epilepsy. It's looking at many domains.
It's looking at
relevant
Rett
to
syndrome.
Thank you. Next question. How did you train physicians about your syndrome? Was it in-person workshops, online, or how?
How do you train?
We brought them to their institutes and they sat in exam rooms together. So Dr. Glaze would frequently, as the core teams from Houston, Birmingham, and Greenwood would travel to those sites in Oakland, Chicago, New Brunswick, New Jersey, and in Florida, the PIs for the natural history study would sit in exam rooms with the hosting physician of those sites. So those sites had to have IRB approval to have out-of-state physicians come on site, and that was a rigorous process as well to get all our IRBs online at the same time. But they did parallel exams, and so they had rating scales, the consistent rating scales that were approved for the natural history study, but even those are subject to inter-rater reliability. So it was side-by-side exams. I don't know if Dr. Glaze.
I think so. I think they did enjoy it. The other way we have, because both of us have academic positions, we have physicians in training in child neurology and training in other areas, molecular genetics. And we've had several go out. So currently at Colorado, currently at Vanderbilt, even at Alabama, we have.
I think important to add, though, is that as of recent, there are some efforts in the making where there's sort of the idea of potentially recording exams and similar assessments and reaching out to really remote sites that way to sort of standardize assessments even to, and you may be better able to speak to that actually, Paige. Yeah.
And that's where RettSyndrome.org is contributing to the
Yeah.
effort. So what we have found works for us is to work with people who like each other. So that's also a requirement of being part of our consortium. So you saw some dots kind of come on and off the map, and we are reaching a nice place where we have 14 to almost 19 centers who really like each other and want to work together and work together with a spirit of collaboration. So where the original PIs traveled to these travel sites, we then went from 7 to 14. Those other sites came to us and said they would like to go to these centers of excellence and be mentored, and we've supported that. And as Dr. Suter said, we're embarking on an endeavor to maybe do some video training to help do measurements. With our population, it's really important. They can't speak for themselves. They're very low functioning motorically. Does that answer your question?
I have one last question that we have time for. It's one that's been upvoted a lot, and I think maybe this is for you, Paige. Data diversity in your case seems like a bad thing. One of the big blockers for larger consortia is the variability in adherence to protocols, especially once you're outside of a center of excellence. How does your team address that?
That's a good question.
So the data management people in South Florida do quality assurance and improvement, and we get monthly reports about how things are going and compliance and things like that. So there is a mechanism to address that issue, to standardize the protocol across the various sites. And we've been able to, I think, successfully to do that.
And that's something you proactively built into the system, it sounds like.
The other thing is actually we use some severity scales and other questionnaires that we have standardized, and again, that's part of the teaching to physicians, to clinician researchers, is how to actually do these, how to do the assessments. So we have kept that in mind. Again, we've been very fortunate that we've been able to maintain a very high standard of quality and standardization.
Thank you. Thank you very much. And thank you all for sharing all your wisdom with us.
Thank you again. On that last question about diversity, that's one of the elements that we'll be picking up right after our break. We're going to take about a 15-minute break. Call it a 10-minute break to stay on schedule, because I think our last session of the day is potentially, it's definitely one of the most important, if not the most important, because it really speaks to not only diversity but inclusion, and that is not just about people, it's about science. So we'll be back in 10 minutes. Thanks.